Hello, I'm Yakeel Quiroz, Associate Professor at the Harvard Medical School, and today I'm going to be talking about some of the work that we have been doing in collaboration with the Colombian families with autosomal dominant Alzheimer's disease. I have nothing to disclose. For the past 30 years, the group of neuroscience in Antioquia, Colombia, has been following individuals with early onset dementia. They have characterized some of the largest families in the region and also in the world. So now we know that in this region of Colombia called Antioquia, we have the largest known families with autosomal dominant Alzheimer's disease, explained by a single mutation in the presenilin-1 gene. Carriers of this mutation, they usually develop MCI and dementia in their 40s and with near 100% certainty. So they develop MCI at the age of 44 and dementia at the age of 49. We now know that there are some similarities in clinical cognitive and biomarker profile between this form of the disease and the late onset sporadic AD. Some of the earliest work that we have been doing and we still continue doing is characterizing the age-related trajectory of biomarker abnormalities in these individuals. The first work that we did was using a structural MRI and functional fMRI, and we showed that carriers compared to non-carriers, they had hippocampal hyperactivation and less deactivation of parietal regions. We also showed that they had thinner cortex in AD-related regions compared to the non-carriers. And we are also able to show that they have abnormal electrical activity using EEG and event-related potentials. Following these individuals over time has allowed to characterize the trajectory of these biomarkers from preclinical all the way to clinical stages using a CSF, FDG PET, a amyloid PET, and others. We now know that there are a lot of changes that start happening several years before they develop clinical symptoms. Most recently, we started doing some work with plasma biomarkers. And in this year in particular, we had two studies, one looking at changes in NFL and another study using a p-tau 217. And in both studies, we were able to show that changes in these biomarkers are seen very, very early in the disease, and they start distinguishing carriers from non-carriers in their 20s. In 2014, we launched this collaboration between Colombia and Boston that is called a Colbus project, and this is a longitudinal biomarker study. As part of this project, individuals from the Colombian families are actually coming to Boston for neuroimaging and other biomarker examinations. What we have learned so far from Colbus is that the carriers, as predicted, they develop amyloid pathology very early in the disease, and these changes can be seen as early as 20 years old in amyloid in the brain. So then we also show that they have increased tau pathology in their late 30s, about the age of 36 and 38, a few years before the clinical onset. These changes in tau pathology are only seen in individuals that have really high levels of cortical amyloid deposition in the brain. And once they develop MCI, tau pathology is widespread in the cortex and is highly correlated with, of course, with amyloid, but also with cognitive decline in the carriers compared to the non-carriers. Some of the work that we're doing now with longitudinal follow-up measures, so has been telling us, as predicted, that carriers compared to the non-carriers, they have greater accumulation of amyloid and tau over time. What is very interesting about this work is that it's actually telling us also that amyloid starts accumulating very slow and steady several years before they develop MCI, and it's followed by this sharp accumulation of tau as they get closer to the age or clinical onset. So one of the goals that we have been trying to accomplish with this collaboration with Colombia is finding some tools that can help us with the early diagnosis of cognitive decline and dementia at preclinical stages of the disease. And one of the limitations of the cognitive measures, many of the cognitive measures that we have, is that they are developed for individuals that already have impairment. So we are very interested in developing measures that can help us to detect some of the earliest changes in cognition that can help us predict who is going to have a greater risk to develop dementia in the future. And this population, the Colombian families, is an ideal group to do it because we know who is going to develop dementia in the future. This is just an example of one of the tests that we are using with them. We adapted and validated this measure that is known as the face name. And we created the Latin American Spanish face name associative memory exam. So it's a test that it has an immediate recall and also a delayed recall. And we use this measure with the individuals that are part of Colbus. And the first thing that was very interesting to us, like just the performance on the measure was actually able to distinguish between cognitively intact or unimpaired carriers from non-carriers, just the behavioral measure. And of course, as they get symptomatic, so the measure becomes even more sensitive to carriers versus non-carriers. Even more interesting than that, when we look at these associations of performance in the measure with markers of brain pathology, we saw that, of course, it's highly correlated with amyloid. So the more amyloid they have in the brain, the worse performance in the test. And also, it's also seen with tau pathology. The more tau pathology they have, the worse performance in the task. So it's just like one of the tasks that can have some potential to help us identify individuals that will develop MCI and cognitive MCI and dementia in the future. In 2017, we launched the Colbus Extreme. That is a project that follows genetic and other protective factors against dementia. We use, for this project in particular, we are following individuals who remain cognitively unimpaired until older ages and trying to characterize what are the possible factors that can explain that protection. The first case that we have, we reported last year, it was an individual from these families. She was carrier of the E288 mutation and didn't develop MCI until her 70s, like about 3 decades after the estimated age of onset. We enrolled him in Colbus, and she came to Boston for brain imaging and biomarker examinations. The first thing that we noticed is that she had the highest levels of amyloid burden that we have seen in the kindred. But even in that context of really high levels of amyloid, she had very limited levels of tau pathology and hippocampal atrophy, especially considering her older age. So she had no signs of glucose hypometabolism in AD-related regions. So we conducted some genetic analysis on her, and we confirmed that she was a carrier of the E288 mutation. And also, this analysis revealed that she was homozygous for a rare mutation in ApoE, the ApoE3 Christchurch mutation. Some of the experimental work that follows that finding showed that ApoE3 Christchurch modulates A-beta aggregation, being similar to what is seen and has been reported in ApoE2. Something that it was very interesting, and it was the first time that it was reported in the literature, is that ApoE3 Christchurch also impairs this binding between ApoE and heparin. And as a matter of fact, this ApoE Christchurch has the lowest binding to heparin compared to any other ApoE isoforms. So we use this information to inform the development of an antibody that pretty much mimics or replicates this role of Christchurch. And this antibody was able to inhibit the binding to heparin, which suggests a potential therapeutics. The other component that I wanted to mention that the group in Colombia and the families are involved is the Alzheimer's Prevention Initiative, particularly the preclinical trial that they are now being part of. So in 2013, this trial was launched as a collaboration between the Banner Alzheimer's Institute, the Roche Genentech, the group in Colombia, and the National Institute of Aging, with the goal to test the safety, efficacy, and tolerability of crenezumab in carriers, cognitively unimpaired carriers from the kindred. So it's a placebo-controlled clinical trial that is still ongoing and includes carriers and non-carriers from the age of 30 and 60. Something that was quite remarkable is that in preparation for this clinical trial, they created the API registry. And as part of the API registry, they reached out to the community at large in Colombia, and they increased the number of participants that we have now available in the registry. And also they were able to identify several other new mutations related to Alzheimer's disease and also other diseases like frontotemporal dementia and other forms as well. So in the trial, so they screened 319 candidates, and 252 were randomized and are now actively enrolled in the trial. So as I mentioned, this is ongoing. So in the future, we will know more, but something that is very remarkable, as I was saying, like now the group in Colombia, they have the infrastructures to be able to conduct this kind of trials. So as part of everything that they're putting together, like a learning from the families, being able to advance the genetics, advance our understanding and the clinical assessments, neuroimaging markers, and now clinical trials, everything together as part of this 30-year history that the group of neuroscience has been contributing. So families with autosomal dominant mutations provide a unique opportunity to study disease progression, as I mentioned, from preclinical to clinical stages. Can also help us to develop and improve measures from early detection, as I gave you an example, and also help us to implement early interventions and clinical trials. There is a need for future longitudinal studies, and not just in this family, but in other families with other specific genetic mutations. We still have more to learn from escapees or autosomal dominant mutations, as I mentioned. So the case that I mentioned is case number 1, and we are very actively looking for other outliers, other escapees that we can follow and better understand the protection against cognitive decline and dementia. And future clinical studies and clinical trials may include new families with early onset dementia. I would like to thank everybody that is a part of my lab and Mass General, and also everybody that is part of the Grupo de Neurociencias de la Universidad de Antioquia, especially Dr. Francisco Lopera, and for all his work for the past several years. And also thank Dr. Eric Reimann of the Banner Alzheimer's Institute for all the work with the API. And particularly, I would like to thank the Colombian families with autosomal dominant Alzheimer's disease and other dementia for their dedication to research. I thank all the funding sources that have made this work possible through the years. Thank you very much for watching, and have a nice day.